Welcome to another episode of the PFC Podcast. The opinions you hear are ours and doesn't necessarily reflect anyone else's. Now on to the podcast.
Welcome back to the Prolonged Field Care Podcast. This is Dennis, and today we have a short one. We have Sean and Andrew going over our latest Prolonged Field Care product, the PFC Critical Skill Task List. Now, just looking at it, this is going to be a great asset for when you have to start planning your prolonged field care training exercise. Now, without further ado, here's Sean and Andrew.
Hello, how's it going? This is Sean, and I am here with Andrew. And today we're going to talk about the Critical Skills Task List. You want to say hi?
Hi there, this is Andrew. First of all, thanks for having me.
We are a couple of ER docs, and so just take that into consideration when we're discussing how we came up with this, but let's just jump into it. So what is a critical skills task list?
So the critical skills task list is essentially a list of over 100 skills that we think are crucial for an 18 Delta or a similar SOCM medic to know when it comes to prolonged field care. The intention behind this list was not to recreate the wheel with T-IC, as these already have well-validated lists, but instead to make a list that was more specific to prolonged field care and the world around it.
Why did we develop the list initially?
So the reason we developed the list was for two reasons. First, we wanted to try and consolidate all the other lists that were out there. There were a lot of smaller lists that had a lot of great PFC skills, but there were kind of too many, and none of them were complete. So the first goal was to do that and create one singular and easily archivable document that was organized in a user-friendly format. So we did that by separating this out into those 10 categories which represent the 10 core capabilities, and then also separating those into smaller subcomponents. And we think we achieved that very well with this document. The second reason was to give people who may be less familiar with prolonged field care a good frame of reference for what these critical skills are. As PFC continues to expand even outside the SOF environment, more and more people are trying to teach and trying to learn this that may be less familiar with prolonged field care. So by having this one document for all the critical skills, we think it's going to give people a good frame of reference to use when they're trying to teach their medics.
And currently you're a Special Forces Battalion Surgeon. You've been in that job for a little over 2 years now, so a bit of experience. You've done some of these exercises. You've trained individuals and groups of folks. How do you think that you're going to use this list, going forward with your guys?
Yeah, great question. So I see kind of two big uses for me when I'm teaching my guys to use this. One is when I'm teaching classes, I can reference this for what I should be including in my lectures. For example, if I want to teach a prolonged field care airway lecture, I can move to that section and go, oh yeah, so when I'm teaching them how to do the airway, I should also focus on ventilator management. Maybe I forgot to do that. And I can bring in like, oh, the troubleshoot the ventilator, teach them the DOPE algorithm, things that I may not be thinking right away. I can reference this, go, yep, I should include that in my lecture. And then secondly, of course, when you're running an exercise, which is one of the larger components we do with prolonged field care, you can use this as kind of a check on learning. So like, all right, so they're managing a burn wound. Did they apply a burn dressing? Are they preventing evaporative heat loss? And are they using something antimicrobial to prevent infection? Are they thinking about those things? So basically, again, it helps me in two ways, both when I'm teaching classes and running exercises, to kind of do a check on learning and a check on what I'm trying to teach them.
Yeah, the thing that I realize, this is a fairly comprehensive list, and it takes into account the post-procedure things, because I think we have a lot of training scars from training in TC3 all the time, and so we get the airway and then we stop, and then we move on to some other scenario or some other procedure, and then we forget that there's a lot of management that goes into it. It might not be fun to talk about, it might not be fun because you're not putting steel on target and putting tubes and lines in, but there's actually a lot of skills that goes into maintaining that patient. If you want to call them nursing skills, maintenance skills, but even things like talking about and practicing sterile procedure is so important when you're looking at this. But we've got a lot of training scars in that we hadn't really practiced that with TC3 in the past. And so I think having this list serves as a good check as to those things we need to go through. One thing, when I think about this, if you took somebody that had never done prolonged field care and you were going to give them a comprehensive course, that could be 3, 4, 8 weeks long. And so when folks say, hey, how do I train in prolonged field care and I've got a 40-hour week? the first thing I say is, well, look at the capabilities, kind of assess your particular medics, what their skill sets are, and then choose those capabilities that you think they could work, that they are trained in, and those things that they need to work on. And then once you hone in on those capabilities, maybe that you're less comfortable with, now you can pull out this list, look at the things underneath that list, and now you've got blocks of instructions that you can develop and really, dig into and dive into those capabilities that you want to practice. And so each unit's training plan may look very different based on what they want to emphasize, but this really, I think, gives blocks of instruction, whether it's a 5-minute block of instruction or a 2-hour block of instruction. It gives some guidelines as to what to teach in order to make them, at least minimally capable under that capability. So anyways, the leadership capabilities, that wasn't really something we thought about when we thought about an individual medic. When you're training a team, when you're training guys maybe with medically trained and unmedically trained folks, what things did you observe that could come out as far as team dynamics that you wanted to train on?
Sure, and this is a great question. So some of the big categories, the biggest one in my eyes is medical command. So the 18 Delta is taking over as the sort of the medical commander of the patient, and this is something that they are sometimes well trained in, but sometimes they don't get a lot of formal training in commanding a medical team. So you'll see a lot of bullets in there about that. And then, of course, medical communication. Everyone who's worked in the hospital setting knows how important closed-loop communication is, how important it is to direct certain individuals to, for example, a simple ACLS practice, and we have a recorder. We have someone who's in charge of airway, someone in charge of, the side of the bed, someone in charge of the monitor. So these are all important skills that we oftentimes overlook, and I think the importance of bringing that in also helps bring in the entire team to the exercise. And so I really think this is a good this particular category is a great way to involve the entire team, including team leadership, the team sergeant, the team leader, to make this a full team exercise and not just about the deltas.
Yeah, absolutely. That's an observation that I had back when I used to run the ER. We would get together and do trauma training or code training, and it wouldn't be about rehashing an ACLS protocol, but it was more going through the individual steps of assigning roles, working through this, and we would use real cases that we had before that went well or maybe not so well to talk about how we could have made it a lot more smoother. Because when you're talking about in a classroom setting and everything's calm, it's easy, but when you've got a sick patient trying to die right in front of you, some people just lose their minds. And so that's not the time to assign people tasks and explain to them how it is that you take vital signs or how you do things. And if you can free up your hands for those relatively simple tasks, then you can take a step back as a senior medical provider and actually wrap your brain around what is going on, what's presenting in front of you, what is going to be your next intervention 10 minutes from now or an hour from now. And you can really start to take a look at the big picture if you can unclutter from the little tasks. It's interesting. I think as we have talked about this in the working group, some of this stuff has seemed somewhat obvious for us, but as other folks not intimately familiar or involved with teaching special forces medical sergeants or special operations combat medics, as other folks want to wrap their brain around this, they're not really familiar with a task list. And usually the background, as you nicely point out right at the beginning, is the TC3 skills. So this is mostly above and beyond the TC3 skill list. Did you find that you repeated a lot of TC3 stuff in this, or is it a foregone conclusion that everyone is trained in TC3?
So there is a slight overlap with some of the T-TRI-C capabilities, only as it applies to the advanced surgical procedures. I found it was difficult to talk about things like how do you manage someone after doing a cardiac thyrotomy without also including, hey, these guys should know how to do a cardiac thyrotomy. So there is slight overlap, but a lot of the basics of T-TRI-C are not included, and we just assume that the learner already knows those if they're advancing to this next step. Of course, the caveat there being, if people aren't good at T-TRI-C, they shouldn't be moving on to prolonged field care yet. It should be assumed that they're already experts or near experts in T-TRI-C.
Right. Yeah, if you don't do the stuff to save their life in the first 15 minutes, you're not going to have a prolonged patient encounter, as it were. So, cool. So, I think this is probably, after reading it and rereading it and correcting spelling and everything, we're at about 95%, but I bet we will probably, as folks use this, we will refine it even further. But the nice thing about this is we can get it out right now on the website, and folks can have something to start with. And then as we get feedback, and we ask for feedback from the field like we do with a lot of these things, we can then refine this list and go forward. But hopefully folks will find this useful. I know you put a lot of work into it, as did some of our other folks in the working group. And it is something that we identified over a year ago. And so I'm really happy that we're able to do that. And I think this is going to be value added for guys on the ground as well as their immediate trainers. And this is good stuff. So I just want to say thanks for taking the effort to put this together, and hopefully everyone out there finds this useful with their future training.
All right, thanks for having me.
Cool. All right.
That's another one for the books. Make sure to go to the site, www.prolongedfieldcare.org. Post your questions, post your comments, make your voice heard. This is Dennis for the PFC Podcast, out.